My name is Fraser Mooney. I'm with Nova Scotia Health, and I'm going to be the moderator here this afternoon. And I'll explain a little bit about how things are going to run in a minute. I hope you had a chance to visit some of the tables out back. Like I mentioned earlier, we have virtual care, we have public health, we have primary health care, EHS, continuing care. We have a number of people who are really eager to answer your questions and listen to any comments that you might have. So if you didn't get a chance, certainly there'll be an opportunity to do so after the session is over. I did want to mention that we are going to have some introductions here in just a sec, and then we're going to get into the question and answer, the Q&A session of the afternoon. So what we're going to have people do is, essentially just raise your hand, and we'll have folks running around with microphones like the old Phil Donahue show to try to get to you. Oh, you watched Phil Donahue, did you? Yeah, okay. I feel like I'm dating myself when I say that, but okay, some people still remember. So we hope to get to as many questions as possible. It's a really big crowd here this afternoon, so we probably won't get to everyone. But when you came in, you would have had a chance to grab a question card. So if you have a question that you don't get a chance to ask, make sure you fill out a question card, put some contact information there, an email address or what have you, and we will respond. We will get back to you. Some of you had a chance to submit a question when you registered for the session today. So if you did ask a question at that time, someone will get back to you. You will get a response to your question. A couple of other things, and maybe I might as well get into it now since I'm talking about the questions. Since we have so many people, we want to have a chance to get to as many different questions as possible. If someone stands up and asks a question similar to the question that you want to ask about, physician recruitment, for instance, if we already answered that question, maybe you could think of something else so we don't cover too much of the same ground. Also, if you have I guess a personal situation, something that's happened to you in the healthcare system, you or a family member. I know it will be difficult for the minister and Colin and others to address personal situations here in such a public forum. So maybe afterwards you can pull someone aside and have a conversation with them afterwards. And also, at the back of the room, there's information about our patient and family feedback line. So there's always a way to express your concern to Nova Scotia Health, and there will be someone ready to respond to you. So, having said all that, and I might go over a little bit about that again in a few more minutes, I think we're going to get into the introductions. And you notice I took my mask off, so the folks who are going to be speaking at the mic will take their masks off just because the session that we're doing is, as you can see with the cameraman right here, the session is going to be recorded and posted online, so people who haven't had a chance to come here this afternoon will be able to watch this session online afterwards. So right now I'd like to ask your MLA, the Honourable Kim Maslin, Minister of Public Works and the MLA for Queens, to do some introductions. Kim.
Thank you, Fraser, and good afternoon, everyone. It is absolutely fabulous to see so many people out here this afternoon to talk about something that's very important to all of us, and that's healthcare. Before I begin, I would like to acknowledge that we are in Mi'kma'ki, the traditional territory of the Mi'kmaq people, and I also would like to acknowledge the people of African descent that have helped shape the history and culture of Nova Scotia for more than 400 years. I am so pleased to be part of this afternoon's conversation with all of you and some of our health leaders. These are very important discussions to have. And I really put the pressure on the Minister of Health and Wellness to come to our community because I wanted people who I represent to have the opportunity to talk to our Minister of Health. And Minister Thompson, I want to say thank you so much for coming. You are an amazing colleague, but most importantly, a very dear friend, and it is a pleasure to welcome you to Queens. We also have some department and Nova Scotia Health staff here with us today, and I'm assuming, Fraser, you will be introducing them for me. And they will be able to provide you with some things that we're doing as government, and obviously some things that we're doing here in our Queen's Jewel. So thank you all for coming. I will pass it over to Minister Thompson or Fraser, whoever wants the mic, to do a little more chatting.
Thank you, Kim. And I think you've heard enough from me, so I'm going to allow the minister to say a few words.
There we go. It usually takes a second. So I just want to acknowledge MLA Becky Drouin, who's here in the room with us from Lunenburg West. And I think probably before I start, I'll get Colin to introduce himself so you know who we are.
Great. Good afternoon, everybody. My name is Colin Stevenson. I'm the Chief of System Integration with the Department of Health and Wellness. Actually, still, I'm not allowed to say I'm new anymore. It's been since June, I think, since I joined the department. Prior to that, I've been with the Nova Scotia Health System for just over 20 years. Was with the Health Authority in the Truro, Colchester area for a period of time, and joined Nova Scotia Health as one of their executive members in 2015. And so lots of experience working through the system in the province, and happy to have had the opportunity to join the Department of Health this past year.
So my name is Michelle Thompson. I'm the MLA for Antigonish. I am a Cape Brettoner. I don't know if there's any Cape Brettoner. Oh, there, I see one. That's, woo, yay. Okay, I'm all right now. I got 2 Cape Brettoners, so I'm going to be all right. So I trained as a registered nurse. I've been a registered nurse for just over 30 years. I left Cape Breton to go to nursing school at St. Martha's and found a fella there, and here I am. I stayed there for the rest of my life. So I was elected in 2021. Certainly, my experience in healthcare, I was frustrated. I had worked in acute care. I had worked half my career at the front line, and I had worked half in leadership positions. And just prior to being elected, I worked this previous 6 years as an administrator of a long-term care facility. So all that to say, Premier Houston thought that maybe I would like to run, and I didn't think I would. So I thanked him sincerely for thinking of me. But then the next thing I know, I was running, and so was elected and was really given the privilege to serve Nova Scotia as the Minister of Health. So I'm just going to give you a little background. I'm going to take about probably 5 to 7 minutes to give you some background about what kind of to set the stage, and then we'll get into questions because I think it's really important. So. Certainly the platform that we ran on to fix healthcare resonated with Nova Scotians. I think we've all felt the deterioration in healthcare for a long time. And so when we, on the first day after we formed government, we created a new health leadership team. So health leadership, in the past, we had Department of Health and Wellness, which I kind of would say would be the funders. They provided the money and they provided health policy, and Nova Scotia Health and IWK were the operators, and so they were the people who delivered service. And those two entities were parallel to one another. So just like there's a gap in the middle of the two sides of the room, that would be similar. There would be a bit of a gap, and although they worked well together, there still was we felt an efficiency that could be realized if we had one singular leadership team. So we now have a health leadership team. You'll hear us refer to it as HLT for short. And it consists of Karen Oldfield, who is the CEO of the Nova Scotia Health Authority, Jeannine Lagassé, who's the Deputy Minister, Janet Davidson, who is really a thought leader in health policy and healthcare. She's a registered nurse. She's retired now, but works as a healthcare as an administrator. She kind of takes the place of the board for now. And Dr. Kevin Orrell, who's an orthopedic surgeon and had been in the healthcare system and a previous deputy minister. So that is the health leadership team. They are intact and they meet on a weekly basis. And even though they all have their own entities to represent, they come together on a weekly basis and make decisions, and it allows us to be quicker. So not this gap in between. And I would argue that we are in contact with one another on a daily basis, at least. I mean, we're lucky if it's once a day, as some of the health leadership folks that are local will tell you. So that was the first thing we did. That was a very important move for us, and it's allowed us to be quick, and it's allowed us to make decisions that we feel suit and support the whole system. And then we set out on a healthcare tour. So the health leadership team, the premier, and the deputy, and me, the minister, all went out. We started in Niels Harbor, And we went all the way to Yarmouth and went all points in between. And we talked to about 2,700 or so healthcare professionals because we had a sense of what we felt was the right thing to do, but we wanted to validate it and we wanted to hear healthcare workers, frontline healthcare workers' experience. And so we did. We met with them over a 4-day period. And we got a ton of feedback. And then we also met with stakeholder groups, so different associations for certain diseases, things like that. We spent a lot of time. And then we have Action for Health. So I don't know if you're familiar with Action for Health. It's a strategic plan. It's the first strategic plan that we've had for healthcare in the province for at least a dozen years. I would argue probably more like 20 years. And it's built on the voices of healthcare workers. And it is accompanied by data that tells you and tells us how we're doing as a healthcare system. We're going to mature in that. Like, we're trying to find the things, like there's things that we measure that maybe we think the public wants to know about and they don't actually care. They're asking, why don't you have this measurement? So we're maturing in terms of how we report back. And you'll get a report. That is a 5-year plan. And it's a 5-year plan because our healthcare system needs to be transformed. So the way we received healthcare 50 years ago, I always talk about Dr. Chow in Badek, which is where I'm from. He delivered every one of us in my family. One kid got delivered in Sydney. We consider him the failure. He had to go over the mountain to be delivered. Oh, sorry. And so, Dr. Chow did everything. He was everybody's doctor, and he did everything. He worked in Emerge, he worked in his office, he delivered babies, he looked after Alderwood Nursing Home. He did all of those things. And so we were in a different time and place then. Things are a bit more complicated now. We're more complicated. We live longer with chronic disease. And our system is different. We have higher demands, and the technology and the medicine that we take in order to be well when we live with chronic disease is different and requires more touch points on the system. But our system hasn't evolved. And so we're in a time now of transition, is what I would say. And when I started my career 30 years ago, I can remember working, and I had to write down, the nurses, I was just a student finishing up, but the nurses had to write down everything they did. It was called GRASP. And we were workload measuring. It was a workload measurement tool. There's people nodding. There must be retired healthcare workers in the room. They remember, they're getting a flashback to GRASP. And so that was the beginning, I think, of when the constriction in healthcare started. We had a sense that it was going to help, and in fact, we lost staff as a result of that workload measurement. And over time, we've tried to take slack out of the system, subsequent governments, and it's been to the detriment of the system. We haven't planned. Somehow we knew all those baby boomers were coming, but we didn't plan for them. So here we are. We need to do a lot of work quickly, and I know that it can't happen quick enough. But what we're here today to do is to tell you about the work that's happening. Not just the financial investment, but the investment in time and money. And today, before I came here, we actually had first in the world announcement that cancer care patients within 6 months will have their own record. It will be connected. We're going to connect all the cancer care programs in this province. You will, if you're a cancer patient, you will actually have an app on your phone that allows you to get data or to give your information directly. If you have symptoms, things like that you can't control, you'll have real-time access. And it's a brand new platform, and it works with new cancer treatments. So there was so much excitement. I wish I could have shown you today about how happy clinicians were to have that. So I'm just wondering if the healthcare past and present healthcare workers in the room would raise their hands. Here we go. It's just about exactly how it goes. Yeah, we usually have about a third, so thank you. I'll do my best to represent all of us, and if I miss something, feel free to jump in. I don't mind. So I just want to thank all of you for the contributions. Healthcare, I say, is not for the faint of heart, but it takes your whole heart. And sometimes your whole heart breaks as you're delivering healthcare because you're, in some of the toughest situations with patients. So I want to thank you. And I just want to say, COVID's been really hard on our healthcare workers. It's been hard on all of us, but COVID's been really hard on the healthcare team. And in the beginning, people were banging pots and being really, there were trays of sweets and all kinds of things being delivered to healthcare workers. And as the time has gone on, that has changed, and our healthcare workers have really had a difficult time. And I would say take the brunt of the frustration often with people not being able to access care. And so I would just like to encourage everybody, first of all, thank healthcare workers, and second of all, encourage folks that if you are in contact with the healthcare system, those are the folks that are showing up for us every day. And I know there's things that frustrate us, they frustrate me too. But to be as gentle and kind with those folks, because we need them. And every time somebody's cruel to them or hard on them, it makes it harder to stay. They're really trying to hang on for all of us. So I would just like to encourage people. I have an email address, and you can certainly tell me about your frustrations. I'm happy to get that feedback. But if we could be gentle with our healthcare workers, I would appreciate it. So anyway, that's it in a nutshell. That's kind of our preamble, and we're very happy to take questions. We're going to get the local leadership folks to come up and tell you a little bit first about what's happening in your area, things you may not be familiar with. We've found this to be really positive in other ones, so you know what's going on with your local healthcare services. And Jeff, I might get you to include yourself in that and talk a little bit about what's happening around EHS when they're done, and then we're going to open the floor to questions. So we usually get to where we need to be by the time the 2 hours is over. So looking forward to the discussion. It really has been a discussion the whole time. We want to hear from you, and we want to give you the information that you're here to find out. So you want to start?
So good afternoon, everyone. For those of you that don't know me, I'm Tanya Nixon. I'm the Vice President of Operations for the Western Zone, and I have a group of colleagues and my co-lead here, but I do want to acknowledge the other Nova Scotia Health staff that are in the room. So we do have some mental health colleagues. Maybe you can wave in the back corner. Michelle Noel has traveled the entire province with us. Michelle is our Western Zone virtual care expert. If you don't know about virtual care, you need to introduce yourself to Michelle. You will hear today that while virtual care is something that's incredibly unknown and unfamiliar, in some cases uncomfortable to people, it is a service that provides you access if you don't have access. And it wraps around you. So if you need something after your initial visit, it can continue to provide care for you. So Michelle can help you with that. We also have public health colleagues in the back and continuing care colleagues in the back. And I do want to bring regrets on behalf of Jody Ibarra. Jody is the site lead of Queen's General Hospital. Jody's had immediate death in her family and is unable to be here today, but it is my incredible pleasure to introduce April. So April, maybe you can give everyone a wave. So April Clausen is so new. If you have visited the site and or the emergency department, I know you know April. April is our brand new, soon to start site lead that will replace Jody at Queen's, and she will start the middle of March, and we're really incredibly grateful to have her at the site. And we have our primary healthcare colleague, so Margot is next to April, and we have Joanne here as well. As the minister said, we have spent some time talking to healthcare workers. We've also spent some time talking to community members about emergency rooms and emergency room closures. We have had, how many meetings, Cheryl? I feel like this is 9 in the zone, Minister? We are the proud winner of the most community sessions in the Western Zone. So I think this is the 9th or the 10th in the Western Zone. We're happy to finish our round in the warmest place in Canada yesterday. I hear you folks held the record yesterday as the warmest place in Canada. And I'm gonna be really quick because I know there are a lot of people here who have questions. Lots of activity in the site around improving access, both emergent access and, more importantly, primary healthcare access. So if you can get care earlier, you're less likely to need emergent care. Really important that I acknowledge EMCI. I see them in the room here today, and our colleague Jeff Fraser from Department of Health and Wellness from EHS will also introduce himself. And we are reducing surgical wait times, and probably the thing you'll hear the most, which we often spend the most time talking about is health human resource challenges and how we can work together with you to recruit healthcare providers. We often find them, we're often the first point entry, but we know communities retain healthcare workers, so really interested in having that conversation with you. My colleagues will introduce themselves. I'm going to pass my mic to my co-lead, Dr. Cheryl Pugh.
Thank you, Tanya. My name is Cheryl Pugh. I am an obstetrician gynecologist, which I may have seen some of you before, probably a lot of you actually. I've been in Bridgewater practicing since 2004, and my role is the Western Zone Medical Executive Director. I co-lead with Tanya, and I think it's important for us to acknowledge that this team is an incredible team and actually provides leadership to not only just the Liverpool area, but to all of the regional and community facilities that extend from Yarmouth through to Kemptville to the South Shore Bridgewater. So it's a huge geographic area, and my role as the physician lead is that I provide leadership to our physicians in each of those areas, and we add not only to the expertise of our groups, of our colleagues from an operational lens, we add medical expertise, and we also contribute a lot of the physician recruitment and retention falls under our area as well. And I just want to emphasize that as a community, it's so incredibly important that you are also involved in the recruitment and retention, not just of our physicians, but all of our allied health professionals. When you recruit somebody, you recruit that person and their family. So it's really important that I'd like to add into Michelle, Minister Thompson's message around being kind. It's incredibly important for us to be kind to each other right now in this environment. It's incredibly challenging. I do want to highlight one of the positive points I'd like to bring to your attention is that in Liverpool in particular, we've recently had an addition of some residency positions here as an outreach from the Dalhousie site. So we're really incredibly excited that we're going to have some additional family physician residency positions here. And for us also to emphasize that as those learners are here, I won't say the strain because it's very exciting, but the workload of those existing practitioners also expands as they're required to teach. So while you get to welcome these individuals into your community, and we hope that they stay in our community, we have to be a little bit patient with some of the extended times that it takes for them to actually learn with you and be able to provide excellent care to you, because the team that's here is a fantastic team, and we welcome their ability to teach our learners coming forward. That's all I'm going to say. I'll pass it over to Alison Lamb, who's our Executive Director.
Hi, everybody. Nice to see you all, and thank you for coming out. So I'm Alison Lamb, and I'm the Executive Director of Acute Healthcare Services in the Western Zone. So my responsibility is the regional sites and the services provided there. So Shore Regional in Bridgewater, Yarmouth Regional in Yarmouth, and Valley Regional in the Kemptville area, and the services that we provide there. So my focus over the last 16, 18 months really has been reducing wait times as it relates to our surgical services. Locally, many of you are aware, and thank you probably to many of your contributions, our redevelopment at South Shore, which will give us enhanced services for day surgery, as well as a new emergency department and an MRI. So certainly lots of activity there. There's a crane up, so thank you everybody. We're excited to have those services in place in the coming years. And we really are focused on recruitment and retention and retaining our staff so we can provide the services that you need in the regional centers. So that's my responsibility. I'm going to hand it on to Darlene, who's my colleague and co-lead.
Good afternoon, everyone. I'm Darlene Davis. I'm interim executive director for Rural Community Health. I am a registered nurse and a fellow Cape Bretoner, Michelle. So one of the portfolios that falls under me is primary health care. So that is one of the main priorities that we have is under primary health care and improving access to care. And in addition to that, like everyone has mentioned, the recruitment piece, we're very focused on that. And also working closely with my colleagues on emergency care services and the recruitment piece and how do we keep the emergency department open for folks. Also like to highlight that we do focus on working with community partners to explore opportunities to provide even more care that's needed in the community. And yeah, so looking forward to the conversation this afternoon and I'm going to hand it over to Joanne Wenzel, who's our Director for Primary Healthcare.
Hi, everyone. It's really great to see a wonderful crowd here today. I have to say, since everyone's talking about their kind of roots, with a name like Wenzel, you know, right? I'm firmly rooted in the South Shore community for sure. So like Darlene said, I'm the Director of Primary Healthcare for the Western Zone. And really for me, that means I work with teams, family practice teams across the zone. It's a really big privilege that I have to be able to work with them. And our goal is, of course, around the access, around strengthening the teams and building the teams to meet community needs. So that's really a big focus for me. A couple of things to mention about this local area, and I bet there's team members in the room. I didn't quite get to see everyone as they came in, but I'm sure there's team members in the room. Couple of things to mention. So we have two teams, so a real solid team here at Queen's Family Health and in Liverpool. But I always like to mention too, and I'm sure folks know in the room, our team in Caledonia and North Queens, and what a wonderful team that is as well. The team here in Liverpool, it's a well-rounded interdisciplinary team. In fact, they were a little ahead of times, I have to say. Pre-Nova Scotia Health, they already had a strong interdisciplinary team with a pharmacist and social worker. And the rest, I'm going to say it this way, the rest of the zone, we're catching up now, right? It's been really, we've really learned from the Queen's team and how important that is. And a recent addition to the team here in Queens within the last year is new funding. We had a nurse practitioner as part of the team, but now we have an additional nurse practitioner as part of the team. And I mention that because of the direct connection to virtual care in Nova Scotia. So that wraparound that Tanya mentioned and that Michelle can help us facilitate. And a virtual care appointment, it's really important to know that if you have that virtual care appointment and through that conversation with your nurse practitioner or family physician during that call, it's deemed really important for you to have a physical assessment or an in-person assessment of some kind. We provide that in the local community with the addition of the nurse practitioner to the team. So I think sometimes that, well, probably all the time, that sets us apart from other virtual care opportunities that are out there, because we can do that wraparound service if you need it. So thanks very much.
Thank you to our Western Zone leadership team. Oh, yes, with the EHS or EMCI. He didn't jump up right away, so I wasn't.
No, he didn't. Good afternoon, everybody. My name is Jeff Fraser. I work for Emergency Health Services Department of Health. My job is to oversee the regulating, or the what, of the EHS system. I came from the EHS system, where I worked for over 3 decades in various leadership positions. Took a little time out for a 2-on-1 for a year and joined back last year with the job to really re-optimize our EHS system. So we thought maybe there may be some questions that come today as a result. There are a few of my colleagues here from the HOW side, which is EMC, who they're our partner in operating the system, and depending on how the questions go today, we may punt a few of them to Charbel and Jan, both executive directors from the operations side. So really high level, some of the things that we've been up to over the last 10 months is a separation of our transfer functions. So our system was built a certain way, where we had paramedics doing all the work. And so we recognize that everybody is pushed, and our system was under a great deal of strain. And this was the opportunity to begin to develop a new way of doing business, which created some capacity for our paramedics. So you'll see, or you may have seen some of these folks. They're dressed a little differently, but they're handling all of our non-acute transfer patients, which really has freed up a significant amount of capacity for our paramedics. That evolution continues throughout the year, and we're going to be adding some more of those transfer vehicles in the coming months to the Western region. You also may have heard about our commitment to support paramedics to go to school. So to become a paramedic in Nova Scotia, it's about a 54-week program. It costs about $19,500 to do that. It's very intense. So as a government, what we've decided to do is we're going to support, for the foreseeable future anyway, paramedic funding. We're going to subsidize that so we can get interest in our communities. And so we recognize that one of the areas in the province that we do have some staffing challenges is the Western region. And we asked Medavie Health Ed, who are one of the lead education providers in the paramedic spectrum, to set a campus up in Southwest Nova. So our first campus is going to be in Yarmouth, and that program is set to begin in the next few months. They've got an open house plan next week, And since we had the announcement, we can't believe it's been an overwhelming response, which is really, really encouraging. So this is really going to help us continue to create the capacity. The other thing we have is we have a paramedic workforce committee that sits once a month. Members, from the health authority, the union, the employer, where we actually sit down and we look at all these issues that are in front of us. We look at recruitment issues, and we also look at retention issues. We realize you got to do one and the other. And so that's really been the focus. The College of Paramedics sit there. We put the issues on the table, and we try to work as a group to kind of clear those barriers so we can improve the working conditions for our paramedics. Paramedics is a tough job, and in the last couple of years it has not been easy, the pandemic and all these pressures that are there. So we're really focused on doing that. Some of the other improvements that you will feel down here in your neck of the woods are, you may have heard about our non-critical care fixed-wing aircraft. So we move a lot of patients between Sydney and Halifax and Sydney, and Halifax and Yarmouth back. And I don't know if anybody here has ever been on an ambulance stretcher, but they are not built for comfort. So being patient-centered, this aircraft gives us the ability not only to move more patients at once, which will free up a lot of paramedic capacity within our communities, but it's much better for the patients, much more comfortable. We're going to use an airplane because an airplane can fly in any weather. It's under an hour flight. And we're still working through the configuration piece, but at this point in time, it looks like we're going to be able to take 2 stretcher patients and as many as 6 walk-on patients. So you can just imagine the capacity that'll free up in Southwest Nova, not in Yarmouth, but the entire area. We're hoping to have that program up and running in late June, early July. It's really depending on, there are some supply issues, getting some of the equipment we need, but we've secured an aircraft, so that we can't wait for that to start. And I'm also excited, and we'll take some questions today if you're interested around a partnership that we're working through Public Works, and they have a community transportation arm. And we're happy to announce that Queens is our first pilot project. And so I can tell you for the year I had out, it's great news. For the 1 year that I had out of the EHS system, I went off and I led the 211 program. And when I was at 211, I really realized what there are gaps within community transportation where people get to appointments. So from an EHS, this is an EHS partnership with Public Works, and hopefully one of many that we'll do over the next year. And those are still patients that need to be moved, but they really don't necessarily need to be moved in an ambulance, even a transport vehicle with a transporter. It's that low acuity, but we need to put these things in place. So my team, we've got not a large team over on the what side, but we've got about 60 physicians that are part of our program. And the last thing I'll leave you with is this neat little program we've put in our communication center. So in Nova Scotia, when you call 911 and you indicate that you need an ambulance, your call is going to go into our center, our EHS Medical Communications Center. In the last year, we've got a clinical paramedic specialist that sits in there. We've actually added physicians, so our EHS physicians work 24/7 in that center. They're supporting the crews, they're supporting the patients, and we're looking for innovative ways that we can, put care plans in place for patients that may not need to go to the hospital right away, so we can put them in a virtual waiting room. And at the end of November, we added a new program where we have a nurse in there. And so we get calls at 911 that people aren't sure, is it emergency or not an emergency? So what we do is we go through a screening process at the start. We make sure that anything that looks like somebody's really sick, we're obviously going to deal with that right away. But if you're on the cusp, we'll send you off to this nurse program. Essentially what this nurse program does is it provides you with an alternate pathway. So you may need to go to the hospital, you may need self-care, you may need an appointment made for you. Those are the things that we're trying to do. So the physicians with the virtual waiting room is about looking at patients who don't need to go to the emergency department right now. So that's a transport avoidance strategy, and it's much more patient-centric. Taking patients to overcrowded emergency departments that don't need to be there are not good for the patients, and they're not good for the system. So we have to respond to that differently. The nurse is all about response avoidance. So right away out of the gate, we recognize that a paramedic is not probably what they need. There's something else. And so we need to make sure we continue to tailor our approach to give patients what they need. So that's just some really high-level things that we're doing with EHS.
Thank you, Jeff. And thank you for that piece of good news about the partnership here in Queens. That's wonderful. And certainly thank you to all the paramedics for the work they do all day, every day. So thank you very much. Well, okay, so we've done the intros. You've learned a little bit about what's happening here in the region and in the area. So we want to know what's on your mind. Like I said, we have the question cards. If you don't if you're not comfortable standing up and asking a question, certainly bring your card to our attention and we can ask that question for you. Otherwise, if again, as I mentioned, if you have a specific personal issue that has happened to you or a family member, that's something that we might want to talk to you about personally afterwards, not here in front of everybody. So maybe you could hold those types of questions till later. And otherwise, I know we have the Minister Thompson and Maslin and Drew in here. I know in question period you have a question and like one supplementary or something like that. So we'll try to keep it to one main question because I know we have a lot of people here who are really eager to have a few words and to have some questions answered. So we're going to do this the old-fashioned way, just like being in school. I'm going to ask you to raise your hand, and we have a couple of people. We have Rachel, and Tamara in the back. Oh, we have Margot. Is that? Oh, look at that. Okay, great. And I just saw a hand go up in the back. Can you raise your hand again? Oh, in the middle, I should say. Margot, you want to?
Okay, I'm speaking as a retired RN, midwife, public health nurse, who qualified in the UK. And I just wanted to know, is there a push to recruit overseas doctors and nurses by making it somewhat easier to pass the immigration protocols and immigration qualifications? Because I personally know how difficult that was, even though I qualified in an English-speaking validated university in Scotland. And also to meet the qualifications and professional, to obtain your professional license as a nurse. And lastly, and this was another huge barrier I found, was to overcome the nurses' union issues or challenges. I just think we have way too many qualified staff driving taxis, doing mundane jobs, working in long-term care. And I'm not criticizing, I'm just saying it's not utilizing their skill set, and I just wonder how much effort is being put into recruiting from our new overseas immigrants, or even helping to bring them here.
So before you sit down, where did you train?
In Scotland.
In Edinburgh?
No, Dundee.
Okay, I worked in Edinburgh for 4 years at the Royal Infirmary, so.
Okay, I was at Nine Wells.
Yeah, yeah. So what I'd like to say is really we know that there is an incredible number of people who want to come and live and work here. Can you hear? Oh, stand up. Oh, okay. This is the first time I've had to stand up. Okay. So yes, we have a significant effort underway. Number one, with the College of Nurses, looking at how best to bring people in, shortening the registration time. Colin, you can fill in if I'm missing anything. So we have been working with them. They've been very good partners with us. So we do want to look at internationally educated nurses to come here. And so a couple of things. There's been a number of missions. And there's more to come. So we are looking specifically at certain countries like the Philippines, North Africa, India, UK, and the States as places where we can bring nurses in. We have been looking very closely at the requirements to come and making sure that we shorten the window and look at people's prior experience in order to shorten that gap. We are also going physically and looking, so there is some work that's happening with labor skills and immigration with Jill Balser to see, how do we marry those two things? So not only do we do the credentialing, but also how do we make sure that people have job offers and things on the spot so that when they come, it's easier for them to settle. So there is some issues around housing. I think everybody would appreciate that. And we are looking at investing in some modular housing as an example to support people that are coming to live and work here with healthcare workers. So there's been a great effort. In terms of physicians, we certainly are in the same boat. And the colleges have been good partners to us, and they have been given kind of those marching orders that the expectation is that we credential people who are qualified. So some of that work sits in legislation, and so we'll be going into the spring session of the legislature in a month. It was announced yesterday. We probably all have cramps, Becky Druin and Kim Maslin and I. Our bellies are already churning about going in there. But anyway, we're going to get some legislative work done that's going to support us in making sure that these folks can be credentialed and that their prior experience can be seen. So there's been a lot of effort around that.
We have one closer to the front here. And I am going to ask you to use the mic because just for the sake of those folks who are going to be watching this online.
All
Thank
right.
you.
I guess my question will be to the minister. My name is Dr. Peter Phillips. I graduated from Dalhousie University and practiced for 40 years. I've been on the front lines. I've done everything from obstetrics to you name it. Folks, the majority of the problem with the medical system as it is now rests on the shoulder of politicians. Canada has the dubious distinction of having the least number of hospital beds, nursing home beds, etc. per thousand in the G20. They ran her too lean and too mean for too long, folks. Hospitals, in order to function properly, should run at about 80% capacity. This gives about a 20% window for pandemics, respiratory syncytial virus, etc., etc. But that was not the case. Hospitals are running at 100% or more capacity in the quiet periods. So when the pandemic and the rest of it showed up, an already broken system collapsed. So we've got a huge problem right now that could have been avoided. These are the good politicians right here. Those guys in the past were not so good. When I retired in 2015 and lived up to my lifelong promise of coming back home, I was up in Ontario. Well, I had to have some care, and I went to the walk-in clinic in Chester. And lo and behold, there was one of my classmates, Dr. Fred Archibald. He said, Pete, I got a real problem. I said, what, Fred? Can't cover the shifts. Would you consider getting your license back? And I said, well, all right, I'll help out, you know, that kind of thing. There's no money and all the rest of it, but, you know, we got a problem. Well, I went to the College of Physicians and Surgeons. How long have you been retired, doctor? 5 years. Oh, I don't know about that. We want $20,000 and you got to go back and train for at least 6 months and then we'll think about it. I said to the college, I don't want to do emergency medicine anymore. Been there, done that, et cetera, et cetera. I just want a restricted license to work the walk-in clinic in Chester. Oh, well, then it's only $8,000, but you still got to go to Halifax and train for 6 months. And I said, I thought maybe a couple of months tailing a family physician around and catching up. I am still a part of the College of Family Physicians. I read a lot and keep up on things, but yes. But anyway, to make a long story short, I passed. And then the lady at the college said to me, she said, you know, doctor, if we gave you your license back, you still might not be able to practice because there's a moratorium on billing numbers for MSI, so I'd be working for free. So yes, did they want doctors? I don't know. And then there's a problem with the nurse practitioners. Wonderful people. Do you know that Nova Scotia had the capacity to train about 40 a year? Am I right, Michelle? Close to it? We're only training 3. Wonder why? Okay.
Just a minute.
Okay, Mom, if I'm wrong, correct me.
Yeah, no. We're training more than that in nurse practitioners in
Now
the
you
province.
are.
Yes.
But
yeah.
that way back you weren't.
Oh, okay. I'm only here to talk about me.
I know, but I'm talking about the bad guys in the past. And finally, I'm one of these guys that's still on that 8-year waiting list for a family doctor. When I got back here and moved to Bridgewater, thank God, I looked around for a family doctor. Called Bridgewater. No. I thought maybe they'd extend me professional courtesy because I was a retired family doctor. No. Called Liverpool. No. Called Lunenburg. No. So I'm still on the 8-year waiting list. When I want care for my family doctor, I have to fly to Ontario just to get looked after. I mean, I use the walk-in clinic and so on and so forth, but you know what I mean. So that's my comments, and I think that this present government, Minister Thompson, Premier and so on, are going in the right way. I laud them for what they're doing, but they've got a huge mess to clean up, and it won't happen overnight. My final remark is around the emergency physician situation. And I sent an email to the Premier after he emailed me. And he said, what am I going to do, Pete? I said, you hightail it over to Europe with a recruitment group. The European medical schools, Germany, France, Italy, UK, et cetera, graduate way more physicians than their market can bear. And their training is equal to what my training was. So there is an untapped resource, because we need some warm bodies and we need them fast, because we cannot accept any more deaths in Amherst or Glace Bay or wherever. Here endeth the lesson. Thank you.
Thank you.
There is a bit to unpack there. I don't know, Minister, do you want to comment any further on what the doctor had to say?
Agree with you. Yep. And I just want to assure people that a lot of the problems that the physician, what was your name, Dr. Dr. Phillips just spoke about, we really are correcting. I know it's taking a long time, but we're doing really good work. We're working very fast. Even for government, we're working fast. So we're trying very hard. There's a lot of red tape to cut through, and there's a lot of processes that have to change. And, you know, it takes a little while to recruit people, but we are working very hard to address them.
Well, my question was, I hear that the Premier has given the green light to the satellite medical school in Cape Breton.
Yes. So there is a medical school that will be starting in Cape Breton as late as 2025. We're hoping earlier than that. So 2024, the first class will come in. We actually also currently, and those seats in Cape Breton will be specifically designated to people who want to practice in rural Nova Scotia. So we really want to encourage and build up our rural Nova Scotian practice setting. And it takes a special doctor to work in rural Nova Scotia. As we all know, those folks are special to us. So, and we've currently, CBU has 5 seats that they've started. They kind of purchased those through a grant from Dalhousie University with a specific focus on rural medicine with a return to service agreement. So the 5 physicians that are going to be enrolled have a return to service, and we're also looking at return to service so that our folks don't get trained here and then leave the province. Yeah.
And we have right here in the third row, we have a question. 1, 2, yeah, third row from the front.
Okay, thank you. My name's Nicola, and I'm a registered nurse. And I just moved from Alberta a year ago to come out here and work. So I've worked for 40 years as a nurse. And we have a daughter who's a nurse in Alberta and a son who's a paramedic who would love to work here. They love it here. But I've got to say, my experience of registering, and I have sent a letter to Kim, has been very challenging. I completely agree with you. The registration here for me to work as a nurse, a Canadian nurse in a Canadian province, I had to write an exam to license here after 40 years, right? Yeah, and a lot of hoops to jump through. It was not easy. This exam wasn't just a medical RN exam, it was provincial and federal policies of Food and Drug Administration. I don't know why I need to know that to look after you, but you know. So a huge exam that to me was really daunting, which I paid for. So my children would love to work here, but they're not going to come and work here when they have to write another exam as Canadian licensed, who also are being paid significantly less than the rest of Canada, right? So I am working. I'm pretty dogmatic. I went through the exam and I'm licensed now, and I'm working in oncology in Bridgewater. My director had to request for special funding to get me hired as a casual nurse when we're so desperate for nurses, right? Why is that happening? She has applications on her desk with people wanting to work here, and it's, well, they won't put in enough hours. No, we're not going to give the funding for it. So there are people that want to work here, but we're not getting the funding for it. And as an old RN, I hate to say that, but it's true, an old RN who graduated in 1984, there's a lot of things here that I see from the oncology perspective that could be so much more improved. Number one, we are still using paper charts here. Everything's paper.
Not after today.
So
You missed the announcement.
So thank God for that. We are going to a system called Area, which we've had in Alberta for many, many, many years. And now they're on full Connect Care, where they're completely paperless, which is good or bad. System goes down, you don't have any paper to get to. But part of what the good thing about going online is that we had a telephone triage team that nurses are dedicated to answering questions for our cancer patients in live time. So we're talking about an app. I don't really understand all that yet, but from my point of view, and we live in Little Mill Village there, so everyone knows they have a nurse in their midst, and they're quite excited about that. They walk by and tell me all their diagnosis, and yeah. Do you think my PSA isn't in a good read? Probably, yeah. But anyway, it's great having a lot of online virtual stuff, but there's a lot of people here that are computer illiterate. Our little construction guy doesn't even have a cell phone, so I was trying to help him get on Maple and access what he needs for his PPIs, and he has no interest in doing it. He's just not going to do it. So having real time, just a suggestion, I'm not sure where this is all going yet, because I know there's a lot of growth, which is fantastic, but having real-time nurses answering the phone for our cancer patients, having their progress note on our computer so we can pull it up. We can triage their symptoms from the chemo, like their mouth sores, the nausea, the vomiting. We can deal with that, get prescriptions, fax them into their family doctors, and they're not sitting in emergency for 8 to 18 hours with things that are very curable and dealt with in a timely manner. There is a phone line they can contact, and someone will get back to them in 48 hours. So guess what they're doing? They're going to emerge, right? And they're sitting in there with all the other infected people at a risk. So that's part of my challenge is we've got to do something about this registration. You're talking about retention and recruitment, and I'm speaking to a number of professional disciplines, be it paramedics, nurses, physiotherapists, that have said, it just wasn't worth it, so I went and worked at my brother's brewery, or, I'm going to drive that cab, because it was just too hard for them to get their licensing here. Okay, so we are very, very behind the scenes, and our oncology unit at Bridgewater is very tight for space. We've got one little table. We've got our director trying to basically get something from Walmart online for us so we have enough room to chart. So I'm really hoping that there'll be some funding that'll inject into oncology as well, because that's just growing, right, as a community cancer center, that maybe with those renovations in Bridgewater, we'll be able to get a new space as well, just to maybe put us on your radar. So that's all I had to say.
So I don't know if there was a question there. Certainly registration is one of the things that we've heard again and again since we've come in and looking at ways to shorten that. I do want to say we always have to be mindful that the college, the responsibility of the college is to make sure that the public is safe, and so we have to balance that. We want to make sure that we have really, excellent healthcare professionals coming in here, and certainly in terms of money, it's hard to believe a Tory government would say don't worry about money, but we have. So I don't want anyone to have the impression that we are holding any money back. There's been record investments in healthcare over the last number of years. We are working around retention of healthcare workers as well. So not only do we need to recruit, we want to grow our own workforce. So we've increased the number of seats in medicine and nursing, LPN, CCA. We increased the wages for continuing care assistants, which I'm very proud of, particularly coming from long-term care. And it's allowed us to open all of the long-term care beds, or most of them, in the province as a result. When I was working as a long-term care administrator in the province, we probably graduated about 300 to 400, I would say, continuing care assistants year over year. And this year we have 1,000 people who are set to register in the spring of this year and work in our healthcare system. And we expect that there will be another 1,000 more registered in the fall. So that's an incredible improvement. And also, as I said, increasing nursing seats and immigration. We know we've been very clear as recent as yesterday. Premier Houston has said we probably will never be the highest paying province, right, in the country. Our tax base is different. It's very hard for us to compete, and when we start in that race of paying more, it's a race to the bottom, because what happens is people start moving, and it's really, we kind of cannibalize one another, and we've seen that. And we're starting to have conversations as health ministers in the Atlantic region about how do we support one another? How do we recruit together? How do we work together so that we're not constantly pulling people to and from and away from places? So there is a lot of work that's happening around workforce. And so I don't want you to think that money is a barrier, because we know we have to invest significantly in infrastructure, equipment, people, and different systems. So we do have to change the way we do things. And to your point, the cancer announcement today, the clinicians were really excited how it would connect all of the cancer services throughout the province. So having those quaternary, those specialists in Halifax, working with oncology and GP oncologists throughout the province, as well as oncology nurses to support cancer care in Nova Scotia. So it's day one. But I'm really encouraged by that, and certainly the energy in the oncology team was palpable. They're so excited about what that opportunity is for patients. So I just want to encourage people about that as well.
Thank you. A lot of good comments and good ideas there. We have one in the back. Rachel, you can. Thank you.
Well, thank you, and thank you for having this meeting today. I must say it's very informative and far more progressive than I anticipated. I have two questions. They're quite short, both of them. The physicians that are coming to this area to do their practicum, are they going to be setting up practices? Are they far enough along that they're able to see patients on their own? I have a family of 3, and the oldest one is 97, and we need a doctor. And I would be happy with anybody I could get. So I was wondering if them coming is going to give us any immediate relief to the people of this area. That's my first question. The other question is that I have used Virtual Care Nova Scotia for my mother, who is going to be 97 on Sunday. And when it first started, I got very good results. The doctor came on, she called me back, we talked, they ordered blood work, we got what I considered to be very good care from a virtual system. However, in the last 4 times that she needed follow-up on her blood work within 2 weeks. We did the blood work, they sent me a message saying she needed follow-up. 4 times I tried to get through, all I get is, I'm sorry, we're not available today. So are we getting more people who are going to work in this virtual care system to accommodate? I'm sure that they've been overwhelmed with the number of people that use the system. So I would assume that's why we can't ever get an answer from them. So of course I wasn't able to do the 2-week follow-up because I haven't been able to get through. But that's my second question. If we're going to have this system for a while, is it going to be better staffed so that it is more accessible to those of us who try to use it? Thank you.
Yeah, thank you. You go ahead. Yeah.
Cheryl, do you want to talk about the physician piece, and then I can talk a bit more about some of the primary care and the virtual care?
Thank you. Sorry. So with respect to the physicians, the residents are who will be receiving in this area. So actually, before I get to that, I want to say we do have a new physician coming here at the end of April. So that is a very welcome addition to this area. She's lovely. You're going to love her. She is coming from the UK. Another success story. So for the residents, what happens is when you finish medical school, you have your medical doctorate, but you actually don't have the ability to see anybody on your own. You require a residency training period, which is at the present time 2 years in order to graduate from the Canadian College of Family Physicians. That's actually changing to 3 years in 2027. So those residents have what's called an educational license. So they can see you, but they have to be under the supervision of somebody who actually has a different type of licensure, and that's actually applicable across all of Canada. That's not just Nova Scotia. So those individuals will see you with their supervisor in this particular location, and they may take a little longer to see you, and that's how we train these individuals, so that when they're actually finished their training, they may choose to come to this area to practice. Where they choose to practice, some individuals who have residency positions in Nova Scotia have what's called an associated return of service agreement, and we're actually increasing the number of return of service agreements so that people will practice and choose to relocate to areas like Liverpool. Does that answer your question? I'm not sure where you are.
Yeah, I will say though, the residency program is a very, 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 very good recruitment tool. And so as an example, we just had a community conversation in Tatamagouche, and they have recently included a residency program, and they've been able to maintain some of those residents because they're in your community. Is it 2 years? 2 years. And so that's your opportunity to court them. We often think, you know, like we want to bring them here and make them settled and whatever. But at the same time, I also don't want communities to feel that they've failed if a resident goes on and moves away, right? So I don't want you to ever feel that you've done anything wrong if someone chooses to leave. People make personal choices about where they live all the time. However, it is a very good recruitment tool. It gives people 2 years to get to know the community. If they, you know, have family, they can bring the family with them. And if they don't have family, maybe there's someone local who could become family, is what I would say. So there's lots of opportunities, yeah. And then just the question about, you're going to talk about virtual care.
Yeah, absolutely. So, so there's two pieces to the virtual care conversation, I think. One is, you know, Virtual Care Nova Scotia was put in place to try and help people that were on the registry. So appreciating that sort of virtual appointment's not intended to replace what your long-term relationship should be from a primary care team or a primary care provider, but people still need access to care. So how do we actually support that? So that's the Virtual Care Nova Scotia model that was put in place. I think right now anybody who is on the registry has the ability to enroll within that. I think it's around 90,000 people maybe within the province that have done that. And I think there's probably about 70,000 people that have actually sort of gone on and you know, tried to have an appointment at some point in time or had an appointment at some point in time. And absolutely your experience is not unique. The more people that came on, the busier it gets, the harder it is to get an appointment. The virtual care team has been constantly adding new people to what they call the bench, the providers that are there to help support that. They've added weekend appointments and they've expanded into the evening. And we continue as a province to recruit people into that because we do see that as something that we're going to need to have in place for a period of time. Like really, for as long as we have people on the registry, we want to make sure that those people have pathways to access. And virtual care is one of, but not the only one that we would say we're putting in place in the province. The intention around that is that if you, from a virtual care, if you have an appointment that requires a follow-up, you should have a pathway to get referred to an in-person appointment. And within Nova Scotia, that's largely through the primary care clinics that are in place. So those would be clinics that are established around the province that give the opportunity for somebody without a permanent care provider to actually have a place to go if they require follow-up. So hopefully that's occurred. If it hasn't, I know primary care team members here within the room would be able to talk to you more about that. The other, which was sort of announced a couple of weeks ago, is how do we actually sort of expand the virtual care experience based on some trials that were done within emergency departments. So if you are, people talk about a CTAS 4 or 5, lower level or less complex care requirements, doesn't mean that the emergency department isn't right for you at that time, but you could have other pathways around how you access care. So we have tried a virtual urgent care or virtual emergency department in a couple of locations in the province. First one is in Truro. The second was actually in this part of the province down in Yarmouth. Has had great success, both from a satisfaction and from being able to get people the support that they need without having to actually wait for that emergency department visit. And so commitment has been made to expand that. So we're really trying to look at how we get more hospital sites, emergency departments onto a virtual urgent type of a program, which would give people different options in the sense of how they can access care, regardless of whether you're on the registry or not. And we continue to try and sort of put other things in place which actually are intended to give you access. And so they're not all attachment solutions, but it's the mobile clinics, It's the expansion of pharmacy programs within the province. I think we've got 4 sort of launched in the Pharmacy Plus, with another 4 or 5 that are starting, 12 to 13 pharmacy association pilots, with the goal of getting that up to, I think, around 23 within the year. So those 2 sort of combination of things could create about another opportunity for 40,000 appointments within the province over the next 5 to 6 months. So lots of investments to try different things to help people, some very sort of specific to those that may not have a permanent provider, and others for people who just need access within the same day or the next day.
And the legislative, like when we go into the legislature, some things are written in legislation about who can work as physicians in the province. Like if you don't, so there'll be some legislative changes which will kind of open up our ability to build that bench. So there is some stuff that has to go through legislation.
I think we have one here and one in the front as well, but I think I saw your hand first, but we'll get this one over here.
Where are we going?
There you go.
Lady here in the blue?
In the blue there.
Hi. I was just have 3 questions. First of all, how are people selected to have a doctor when a doctor comes? Is that entirely up to the doctor, or how does that work? Next of all, how many people work in the virtual care to answer phones? Yeah, okay. And my last one is, I need blood work. Do I go online, go to outpatients and wait, or can a pharmacist request that I have it? Because he knows what I'm taking for medication. So it's been 2 years since I've had blood work, and I feel it's time. So do you have an answer for me, please? Thank you.
Okay, what was the first one?
Oh, the first one?
Yeah, the first
Sorry.
one. Sorry.
How are people selected to get a doctor when a doctor comes?
Okay, that's a good question. So I want to talk to you a little bit about the Family Practice Registry, and you can fill in. So the Need a Family Practice Registry is a list that pre-existed, and it simply is a list. So there's a couple of ways. Sometimes a physician, and Dr. Pugh, you can correct me if I'm wrong. So sometimes a physician leaves a practice and another physician comes in behind and takes that practice over, and so they wouldn't necessarily take anyone off the list because they're actually servicing the patients who are there prior to. If they sell their practice or however that works, because they're all independent, or many of them are independent. I know. I know, but in the day, I don't know, sorry, but like when they come in, we would work with them. Yeah. So that would be, part of what would happen. The list is problematic in that it's just a laundry list of people, like it's names, and we realized very early on that it doesn't really triage people, and it doesn't give you any ability to go in and update what's happening with you. So I may be on that list and not have any healthcare concerns, but I don't have a family practitioner, and then maybe I get sick, but I don't have any ability to go in and say on that list that something's changed for me. So they're working now to make that list more functional. A year ago, everyone on that list was contacted to make sure they still needed that. The other thing is nobody can come off of that list unless you call back and say, can you please take me off the list? So the list is we're looking at how we make that a better tool so that we understand what's happening with people. Physicians do build their own practice. We do work through 811. I don't know if you have anything you want to say about how people come off the list, but we are working at processes to make it more patient-specific, more patient-centered. You want to talk about the list, or do you have anything to?
Not much more to add. I think most people who actually, it's a higher percentage of people are actually coming off the list to a provider than there are people finding a provider through some other means. So it's not that a physician can't and won't take somebody through other conversations, take family members and things along those lines. We know that that actually happens. Physicians who work in emergency departments or in other clinics see somebody, they're in need, they need follow-up, the physician may agree to take them. That certainly occurs, and it's not discouraged. I think it's probably 70% or more of people who actually come off the list are still coming off through the registry. Right now, we want to get it to a place where there's an understanding of priority and what the clinical need is, but the information in the registry doesn't allow us to do that yet. Joanne, did you want to add? That's what you wanted to say?
And then some folks are actually identified through the primary care clinic that we spoke about, so that they're taken in, looked after, and then transferred to a new physician when they come into the community. The second one was how many people?
Yeah, do you know? I don't
think
know.
there's about 60. Well, we're increasing all the time. I'd have to get the exact number for you, and if you submit your card, we'll email that to you. I don't have the number off the top of my head, but we're building all the time, and it's not just family physicians, it's actually also nurse practitioners, and so continually bringing people on. And the number of people isn't always reflective of a full-time equivalent. So if I'm a family physician and I work in a practice or I work in a hospital, I may do some shifts. So it's not like person for person. Not every single person is full-time. Some people would work a certain amount in virtual care and some people would do other things. So it's hard to say the number. It would really be around the full-time equivalents, like how often it's staffed. I know that's complicated, but it's true. So the number might look really big, but the full-time equivalents might be a little bit lower, so I'll have to check for that.
I think the last question was around access to and blood work. So, the Pharmacy Association Nova Scotia clinics that we kind of talked about, the 13 that have been launched. Part of what's being looked at within that relationship is the pharmacists have the ability to have access to the information so they can look up your results. So that part is absolutely happening. Not all pharmacists, to be a private phlebotomist, you need to have a contract with the health system in order to draw blood. So if you're looking to have blood drawn, you still need to go online and book an appointment in order to go and do that.
Well, it depends. I can think is it the actual needle you need, or is it somebody to order it? I think that's what we're trying to figure out. So maybe what we'll do is follow up with you afterwards, just to see what exactly the issue is that you're trying to navigate, and we'll help you. Yeah.
I think we have a question right here. Yeah, right here, Rachel, and then
this lady or this gentleman here? This gentleman was. Where are you?
Oh, yeah.
Great, thank you. How you doing today?
Good, thanks. How are you?
Good, thanks. So, what is the government doing to increase pay for doctors? Because the bottom line is we're not going to get more doctors to retain doctors unless we start paying them fair and equal when there's other markets that are drawing them away constantly, like our brothers to the south. So that's one issue. Is the government also deferring funds from non-essential government projects to help deal with this crisis? Because if you're not, then why are we spending money on curling rinks when we need more doctors? And that being said, we all know that previous governments and bureaucrats broke the system. Who's being held accountable? Because I'm personally tired as a taxpayer who took a huge dock in pay to move to this province. So to say that Nova Scotia is, taxed whatever, no, you pay a lot of money to live in this province and you get very little service. And that's the bottom line. I've lived all over Canada. I pay more to live here than anywhere else, and I have the least amount of services. And that's not a joke. That's from experience living across Canada. That the people in Nova Scotia are getting hosed on their taxes for what you get. So who's being held accountable to fix it? Because we're tired of waiting for it to get fixed. My last question is, you guys took over 2 years ago, give or take. How many more doctors we have in the province in 2 years?
Okay. Yep, there was a promise, that's for sure. So in terms of payment for physicians, there's a couple of things. So we do have recruitment incentives for physicians who live in rural communities. So they're quite generous. We feel that they're very competitive. The pay for physicians is negotiated through the master agreement, and it's done in a number like 4-year increments. And so we actually, the province and Doctors Nova Scotia is currently working on the next master agreement. And Doctors Nova Scotia is represented by physicians, specialty physicians, as well as GPs, as an example. So they work together and they represent their colleagues. So negotiations have recently started in terms of pay. One of the things we hear from doctors, so there's three ways that physicians can get paid, and I think we're fairly unique in that way in this province. So you often hear about fee-for-service physicians, and we also have alternate payment plans, which are similar to a salary. And we also have a new thing that's coming so that Physicians can have a combination of both if they want. So we have found, and in discussions with physicians, it's really important that they can choose. We hear about salaries and APPs, but there are actually some physicians who prefer to work on a fee-for-service. So like each service is how they're paid. So we feel that that choice is really important because it's also about work-life balance. And we certainly, you know, the Premier and Doctors Nova Scotia and I met this week actually to hear directly from physicians. So we want them to be content here. In terms of accountability, we do have a plan, Action for Health, and there is a website, and I would encourage you to look at that. And then we have a daily dashboard that talks about how the system is performing so that you can see, and it's not just a moment in time. There's different ways that things are trending so that you can actually see if things are improving or if they're not. And, you know, to be honest, there are some things that we wish were better. And so that's part of the accountability, so you can see, all of you can see what's happening. The accountability, it really is, we have to transform the system. We need to do things better. It's going to cost money up front. And what I would say is, so I often say to colleagues that I am really the minister of the healthcare system. But there's also ministers of health in every single department. So the things that we do in other departments are really important. So we have to continue to spend money on things like education, like roads. I know for any of you that are living on a dirt road, I have lots in my constituency. We are funneling the majority of money towards healthcare. There's no question about that, and we're looking for increased partnership with the federal government, and we recently had a bit of success with them. But there are other things that have to happen that are health. So the curling rinks are part of health. They're part of health promotion and prevention. And so we have to balance all of those things. But there will be things that we're not able to do that a government we have to choose. And right now, fixing healthcare is the priority, and we've certainly said that. So there will be things that don't get done because we are fixing healthcare, but there are also services that we need to continue to maintain and invest in. So we want to invest in some recreation facilities because they keep us well, A, and B, it helps us retain young families. So we also have to balance that as well. We want to have communities that are, you know, appealing to people who come and live and work, and a healthcare system that functions is a significant part of that, and I know that. But other things as well. So we can't give up everything just for that, but I will tell you the majority of our expenditures are going towards healthcare to address it. And in terms of being accountable, we're 2 years in, and we've been making progress, and we feel accountable every day. The Premier is a chartered accountant, and he wants accountability, and he wants things to move quickly. And so we're doing that and looking for metrics so that we can report back to the public in an easy way about what we're doing. So we've never had this amount of data that's been available to the public, and as I said earlier, I'm not saying it's perfect, but we certainly are trying to demonstrate to people what's happening, and if it's not good, we put it out anyway because we want you to know if there are areas that we need to improve on. So that's kind of where we are. We will mature as we move on, but I can tell you that the commitment from the Premier and the direction to our caucus and cabinet is that healthcare is the priority.
Hello there, I'm Ashley Christian. Thank you for coming today and answering our questions, but more importantly, listening to the feedback that we have. I am a healthy 36-year-old woman who spent 5 days in the hospital in 2021 with Lyme disease. Ticks are a big problem for us all across the province, but I would really love to hear what your department is doing to research Lyme disease and to eradicate, but help us manage it here in Queens County.
Yeah, that's a great question. Yeah, thank you for that. So we've heard a lot on our travels. Probably at least half of our community conversations have this topic of Lyme has been brought up. So the first thing, which I think is important, and some people will know and some people don't, if you do get a tick bite, if you present to a local pharmacy and you bring the tick, you can actually get service directly from your pharmacist for prevention. So I know that's not treatment of Lyme disease, but I think it is important that people know that there is, because often people will go to the emergency room. So you do have immediate access with pharmacists locally if you do find a tick. So we do know that currently there is a clinic in Fall River that people are attending that is like a chronic disease clinic, but we have reached out to a Lyme disease clinic in Manitoba to understand their process and what kind of care they deliver. So we're in the early days of understanding what's happening in other jurisdictions. So we know it's an issue and certainly is something that's come from these conversations. So we're in that stage right now. I guess there would be more to say soon. And if you want to keep connected through Minister Maslin, certainly that would be a great opportunity for us to continue to report back.
I think we had another one over here. There is one down in the back. We haven't been on this side of the room too often, but maybe we'll go to this one right here and then head down to the back.
There you go. Thank you, and I'll reiterate what this young lady said. It's a great opportunity to be able to talk to you and discuss our concerns. It's just really what this lady said and what this gentleman said. My understanding is that Nova Scotia has one of the lowest paid, has some of the lowest paid physicians in Canada. I don't know if that's correct. That's what I've heard. However, I personally don't think that you can put a price on someone's life. And if we need to increase remuneration, salaries for physicians to come here, then I think that should not be a priority. I think that should be a priority. I know we'll never be probably the highest paid, but at least equivalent to the rest of the provinces. Secondly, concerning the list that you called for a doctor, I had a doctor, he retired. I got another doctor a few years later, she left. After a year. I think she's still here, but she left her private practice, and now I'm without a doctor again. So where does that put me on the list? Have I gone to the bottom of the list where I had a doctor and now I don't? Or am I still at the top? Thank you.
Okay, so I don't know if you want to address the fee. Do you have a sense of the fee for physicians across the country? I don't. I feel that we're competitive. Yeah. I
got it. You're going to need this, eh?
Is it on? Yeah, I guess so. I don't know. When I arrived back here in 2018, the Nova Scotian physicians were the poorest paid in the entire country. That is a fact, Jack. Okay? A third of what they made in Ontario.
Right.
Now listen to this. This will get you going.
Do you have to get them going?
No.
Come on.
A family doctor who graduated from, we'll say Dalhousie University, finishes training at Dalhousie University, could make $60,000 more a year just by going to New Brunswick. Yes, wow. I talked to one of my colleagues, which I've met since I've come back, who works in the emergency department in Bridgewater. She says, Peter, I'm making 1/3 of what I could have made in Alberta, where I'm from. 1/3 of the Alberta fee schedule. Okay? Now, I understand that some of the gap has been narrowed just prior to our present government coming to power. And I don't know where the present status is.
So I think we should probably talk about the present status.
Yeah. Okay.
Rather than getting, we have to.
So there you go.
Yeah. I think the work is happening now in negotiations.
So I can't speak to the exact percentages, but what I can tell you is that the last round of master agreement negotiations brought Nova Scotia very clearly in line with the rest of Canada. There are some areas where we fall short, absolutely, and the last round actually took specific areas that were far below national average and brought them above. There were some areas that we targeted, specifically anesthesia, obstetrics, gynecology, and I am failing to remember some of the other targets. But Doctors Nova Scotia represents the physician group very well. Mm-hmm. So I think, to answer your question about where specifically do we fall, I don't have those numbers, and absolutely we can get those for you, and Doctors Nova Scotia would have those statistics to provide. I do want to address one other question, though, that was raised by the other lady who asked how many physicians we had recruited, and I'm just looking at our actual numbers. From April of 2022 to December 2022, we recruited 113 physicians across all zones, 57 of those starts were family physicians and 56 were specialty. But that's only, that's not the entire year. I think it was 163 in total for the whole year.
I'd have to get the cumulative numbers. We are doing well in terms of our recruitment efforts, and looking at ways when people leave the profession, if they want to retire, that they can also continue to contribute to the system. So some people, they want to maybe give up their practice as an example, but could still contribute in a different way, maybe through virtual care or through after-hours clinics. So it's hard to give you the exact number of who's actually fully left the system, because we do continue to look at ways where some physicians can actually continue to contribute it, as well as nurses. There's mentorship programs, there's virtual care, these mobile clinics as an example. We have a retired physician who's taken on the mobile clinics and is helping recruit former colleagues and things to work with them. So it is difficult to give you the exact number. And then around the list, we can check to see, to look into it specifically for you. But I think what's important is, I can't tell you where you are on the list. Yeah. Yeah.
Yeah, I think if you got a provider and you removed yourself from the list.
No. I had a family doctor for 40 years.
Yeah.
Yeah.
A new doctor came, and I was called, and I was able to have her as a family physician. Within a year or two, she gave up her practice to go work on the actual medical court and understanding. So that left me without a physician again. So I recalled to say I'm now without a physician, but I don't know where I am.
Okay.
On the list. Am I back at the bottom, or am I?
I wouldn't think you were fully, I think we have to check. We wouldn't say you were fully at the bottom. No, but in general, no. And we look at the area as well. But you actually raise a really good point to talk about health homes. So when we talk about those doctors, like the team that you have here, like I think you mentioned it earlier, the way forward is really team-based care, because what happens is there may be times that we have physicians that come and help out. They're called locum physicians or locum nurse practitioners. And what the new way is, and you'll hear the Canadian Medical Association and you'll hear doctors talk about having a health home that has nurse practitioners, family practice nurses, physicians, maybe a physio, social workers, and you're attached to the clinic as opposed to that one provider. So that if the provider, for whatever reason, retires or decides to move away, or there's a lot, gets sick, him or herself, then you're still attached to that clinic. And the other thing is too, we were all in a position where we went to see our physician for everything. Like I lived in Quebec, the doctor pierced my ears, for God's sakes, when I was in the 70s. But now doctors have the scope of practice. So what we're doing is looking at what does each profession do? Like what does a nurse do? What does a social worker do? What can a pharmacist do? And making sure that those teams, so that you may not need to see the physician every time you go. Maybe most of your care, for an example, will be delivered by a dietitian and a pharmacist. So these teams are important so that if a physician comes and can only stay a year, you're not left in a position where that provider is the only person that has you. So that's why those team-based care is so important. And we hear from physicians coming into the profession that's how they want to practice. They want to work in these team-based care, which is what we're starting to build here. So the addition of a second nurse practitioner in that clinic is really essential. So we're going to keep working on recruiting those teams, getting not only physicians, but looking at what other skill sets and professions would be helpful in order to deliver care to you.
I think we have one right here, Margot, and then there is the one in the back, and then another one up front as well. So we'll try to get to as many as we can.
Hi. I saw an article in the Coast where our wait numbers have doubled since 2021. Any response?
Is it which wait times?
Wait times to get a doctor,
For
just so you can have you could have a private physician. The wait list has doubled. This was in the Coast, right?
Yeah,
I didn't write this.
No, that's right. No, I wanted to see which wait list you were talking about. So there our Need a Family Practice Registry has increased. I believe it's around 133,000 people now. And about 30% of that, you can correct me, has been driven by our population growth, first of all. Like we just recorded record immigration. So I think over 12,000 people have moved to Nova Scotia. And in total, it's actually the size of Sydney. Like in the last couple of years, we've increased the population of the province by the size of Sydney. So it's pretty significant. So that's part of what's driving our need a family practice registry. The other thing is around retirements, primary care retirements. And so we know, I think it's 20, I think there's some docs in the room, but 25%, around 25% of our physicians in this province are 60 years of age and over. And so we have to move forward to all of the things that we talked about today. Number one, increase our ability to train, but a doctor takes a long time, 10, 12 years. So that's why the immigration piece is so important. And there are a number of missions that are happening. We're recruiting docs. There is some legislative changes that are coming in the sitting that will help make it easier for physicians to come and resettle in our province. So we do need more doctors. I think there's about, I don't know, do you know the vacancies? 190 vacancies. So we do know that we're behind. This is not, that's, you know, we've known that. We knew that when we formed government. We continue to recruit, and we also know that we have a retiring population of folks. So trying to extend those doctors if they're willing. Many of them are hanging on to their practices, waiting, trying not to let their practices go until there's an alternative for their patients. And so we're working in communities to understand the needs. So we can tell by community, there's a lot of data, people to say where we need folks. So we continue to work. But yeah, the numbers are going up.
What percentage of the provincial budget is devoted towards healthcare?
So,
and the number too, please.
Yeah, so it's about, so I think it's a half. It's about 45% of our provincial budget. So I have approximately a $6 billion budget. Yeah. So it's pretty significant.
I'm a come from away. I have to go back to Calgary to see a doctor. I'm wondering if I can get a half cut in my taxes. I don't think I'm the only one.
Yeah.
Anyway, that's the end of my questions. Thank you.
Right down in the back there.
What's that? Hello? Hello? There we go. Well, I look around the room and a lot of faces I don't recognize, but I'm a third generation from this town. My grandfather came over from England. My grandmother, she was from here, you know, they did the hanky-panky. My dad was born and then I come along. I've been home stuck on a WCB claim due to my work injuries here in a while, so I've had some time to sit back and just reflect on what's going on in a large scale, all around. I'm a Libra, and I analyze the shit out of things. So I look for multiple sources to find information on multiple things. I'm a father of two. I've got a 3-year-old and a 5-year-old. I've watched this community since I was a kid. I can remember when I was first able to go to downtown. You could not find sitting room downtown. The parking lot was full of people, vehicles, businesses were booming. And over time, they kept pushing away. Everybody getting finished school saying, I can't wait to leave here, I can't wait to leave. That's not gonna bring doctors to us. That's not gonna help our medical system. Pushing everybody away because the jobs weren't here. Slowly over time, they took away our industries. And that was all because they wanted cuts. Now we know this is all leading towards money and greed. We're a victim of big pharma. And so is our government. Everybody that's in this room is a victim right now because we're all being played. We're all being played on a system that we think is going to straighten itself out. That we're going to depend on somebody else to do it for us instead of stand up for ourselves. They're separating us in so many ways, whether it be by race, religion, culture, your beliefs, your age groups. That stuff needs to come to a stop. There is multiple forms of democracy, and here's where government gets away with it. If you were to take a form of democracy and call it shareholder democracy, now, I can go and brag democracy all day. I have the freedom of democracy, and my democracy is my shareholders. money, okay? Or you can have the democracy of we the people, or the Constitution, all right? Which is what our founding fathers worked on to bring forth to us so that we could be here in a place called Canada where at one time, everywhere in this world, we were looked up to because we came to your rescue, but not no more.
Do you have a question? I know we have a few more
The questions, okay, yes, and I guess what I'm getting at with regards to this scenario that I'm listening here with regards to the health industry is, for starters, this is all leading us towards more separation of people, like people to people, and more towards tech. Tech is susceptible to being hacked, period. I have online banking with RBC. I got hacked. Now that's banking. That's very like right up there. Like you don't touch that stuff. We got you covered. So that in itself is telling me that for us to put our resources into actually depending on an online system that is operating off of power, which cyber attacks and stuff, you look around and listen, the world's pretty crazy right now. And there's the question is with regards to being able to know that I am going to be coming to a system that is going to be there to support me and my families. It seems as though what has been happening is that everybody that's been here is being pushed out and is looking at being replaced in some form of another. I don't understand. I'm looking at this government and I am wondering the best interest in here, in the democracy point of view, is it for the shareholders or is it going to be for we the people? Is it going to be for the citizens of this community? Because like I said, as I've been a community citizen for 3 generations here, I've watched things deplete and I've yet to see action. So I asked, why not take the mandates off? Why not have so that the workers that were forced off work because they wouldn't get a jab that's a synthetic vaccine, why not bring them back to work though? All right? They're already willing to come back. What about the ones that are retired? Why not come give them a year, 5-year contract to take back to work till we get this straightened out?
We're gonna try to address some of that. So thank you very much.
I lost my family doctor.
I think there's a couple points there. I think it's important that we have a system that there's different entry points for everybody. I think there are people that will do well with virtual care. I think there are people who will do well with in-person, and I think there's a hybrid for both. And your point around our privacy is really important. So we do go through very stringent reviews to make sure that we are looking at people's privacy, and we do want to make sure that information is not hacked. And so I want to reassure you that there is a process. We have digital people that are way smarter than me that know how to make sure that our privacy is protected because we don't want to share individual data with anyone. In regards to the mandates, I will address that. It's been raised at a number of our sessions. So in regards to Nova Scotia Health, we do still currently have a mandate where people who are unvaccinated are off work. There are about 130 out of 25,000 employees who are currently not working in the Nova Scotia Health system. So we do know that, that things are changing and evolving. And what I think the CEO has said in other ones, and what I'll say here, is that we currently are not reviewing that policy, but that does not mean that it won't be reviewed in the future.
Margot tells me that there's been someone very patiently waiting down in the back, so.
Hi, my name is Monique. I was a ward clerk for 16 years at Queen's General. I worked in pretty much every department all over the place. I noticed when we went from our district, the South Shore District, to the Western District, the big district, within a year, the paperwork and changes in policy, in just the simple document formats. Like on average, every 2 weeks, there were changes. And that has kept going ever since. I retired in October. Every time I go in the hospital, they say, "Are you coming back to work as a casual? Are you coming?" And I go, "No," because I can't keep up. I couldn't be away for 2 weeks and come back because there's just constant changes. And at one point I started saying, there's a lot more managers now with this big district. I've seen the pyramids, and it's like there are people behind desks justifying their jobs by making more work for us. This is why a lot of nurses did not want to come back. And I'm sorry, but it's kind of like we're reinventing the wheel constantly. How many wound care documentations do we have to get? And every time we do it, there has to be an education. So we have to take nurses off the floor. We have to bring somebody in to educate them to how to do this new form. And it's just a circle that goes around and around. And it's one of the reasons I won't go back. So I'd like to know, I know we're going to this virtual, but still with virtual, we're going to have to go onto a computer and go tick, 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 tick. And putting a chart together, I don't know if people realize, there's over 36 pieces of paper that have to be reviewed. That's just when the patient enters. And then from there, it goes on and on. And it's like we're bogged down in paperwork. Well, and we're going to be bogged down on computer work. And not enough computers on the floor for all these nurses to sit there and chart. As people say, oh, I went by and they're all sitting down doing nothing. No, they're charting. They're, but we don't have enough computers on the floor for every nurse to computer chart. So I don't know how we're going to do that format.
I'm going to tell you. I'll tell you about it.
Oh, you're going to give us laptops?
No. So what I'll tell you is, you're right, there is a lot of red tape. And there's work underway now for us to take actually 500,000 hours of red tape. Our family physicians in particular, our nurse practitioners feel it very, very heavily in their offices. The number of forms is impossible, and it takes away a ton. So we feel like we could add hundreds of thousands of appointments. In regards to the hospital, I will tell you we're getting one patient, one record, and it's very different from Meditech, is what I want to assure you.
Yes.
I was there when they installed Meditech. I was there when people wrote their resignations at the desk.
Meditech.
There you go, okay. So it is very different than Meditech. So I will tell you, one patient, one record is a digital solution, but to your point, it comes with a whole, it's technical as well, like physical infrastructure. So I just want to reassure you, I had a lot of reservations because of my experience with Meditech in those early days. And I was out to see the new system, the Cerner system, one person, one record in Vancouver. And I was in a 50-bed intensive care unit, so you can imagine how busy it would be. And it was peaceful. And I actually had an intensive care physician singing their praises about their ability to look after patients and see things in real time. I asked the nurses about the workload. They have these, I can't remember, there was an acronym, but they had actually their own computers and at the elbow support, similar that you would have provided in Meditech, but a little bit more enhanced. So the new system is just that. It's, our healthcare providers will help us inform and build the system here, but you're absolutely right. The other thing that it will do is standardized care. So like you said, things change, what have you, and then there's this way and that way. But this will standardize it. So if we will have, even though we'll tailor it specifically to, Queen's General, there still will be care that will be the same. But to your point around education, we do have a responsibility as healthcare professionals to come in and have regular updates so that we do know what to do. And if we get a new product, as an example, or a new approach to wound care, we do need education, because if we don't use those properly, we could cause harm, and we would never want to make anything worse. So that is a drag. The other thing is nothing talks to each other. So we hear again and again from patients, every time I see somebody new, I need to tell my story again. I need to say it again and again and again, and it's very, very frustrating for people. So this one patient, one record, it will be implemented over a period of time. So within 10 months, providers will be able to see what's in it, because we have to put things in it from the past, right? We want to make sure that your health record is there. And then incrementally over time, we are going to increase the function of it so that it actually, it will talk to all the people. They gave an example when we announced it, that if you need an ambulance and you have a child that's sick in Canso, which is a good example, right? Immediately, if that child were to need IWK care, the doctors can sign in and see exactly what's happening in the back of that ambulance. And if they had to stop at St. Martha's Regional Hospital, they can then get some support there, and then they can come to the IWK. So immediately, the people that need to know can be engaged in this system, and it will be pre-hospital care, because the other thing is we have a ton of systems in this province, and they don't speak to one another. So you'll come from the hospital in my home community, and you'll have a chart photocopied with about 40 pieces of paper, and the paramedics will tuck it under your feet, and then we'll take you to the next hospital, and they'll punch holes in it and put it in the back of the chart. And then you have to tell your story again, because it takes too long to read the 40 pieces of paper. So I feel your pain. I've lived your pain, and we are focusing on, because we want people, if you're not at a desk, you're with your patients, right? Whatever role you're in, whether it's ward clerk or nurse or physician. So that's what we want. We want to redirect to the front line.
Well, I'd like to say, if you want to know about every department, ask a ward clerk, because they have to deal with,
You
I
make
have
the
fought
world
for
go
more
around.
food, I've had to fight for
Absolutely.
maintenance, I've had to been on the phone 45 minutes with EHS.
Kingpin, queen pin,
That's
queen
it.
pin. I know, and you never want
Ask
the ward
clerks,
clerks
they'll
mad. I'll tell you
fix
that.
everything.
Yeah.
No, I know the minister is meeting with members of the community later on this afternoon, but members of our Western Zone leadership team are sticking around. We are at time and being respectful of everyone's time. I know we haven't gotten to everyone's question, so please take a moment to write down your question. If we haven't gotten to you on one of the question cards, put some contact information there and leave it with one of our team members. Someone will respond to you. I do want to thank everyone for coming. Thank you for the good questions, the suggestions, the comments, the concerns. Take some time to visit the tables at the back, and please drive safely and have a safe weekend. Thank you.